next is about the rectal cancer. Incidence of rectal cancer has increased in recent years. Now there is a bit of issue of controversy. As per the certain reports, particularly the eastern-based countries reports, the incidence of rectal cancer is increased by about 90% in 1992-2016, and compared to the colon cancer. But there are some other statistics which present the other way, like from 2011 to 2019, incidence rates have decreased by about 1% per year in adults of rectal cancer. Now, this difference again is a sort of regional issue. In the Western countries, the incidence of rectal cancer is now decreasing because earlier the incidence was more, whereas in the Eastern countries the incidence is increasing now, where the earlier incidence was lesser. The reasons could be mainly due to the diet. As far as the Indian data, the data about the Indian rectal cancer incidences, incident rates in India has been considered to be about 2.8 per 1 lakh women and 1.6 to 5.5 per 1 lakh men. That's the incidence calculated by the colorectal, the Central Statistics Department. The incidence has increased in India by around 20% from 2004 to 2014. Now, the reason it's interesting issue is in the Western countries where it was more prevalent earlier, it's reducing. Eastern countries, including India, the incidence is increasing at rapid rate of around 20%, which is quite significant. And the reason is mainly because of the pattern in the diet, change in the diet. Earlier, the Eastern countries, particularly in India, the diet was mainly a high residue diet, like vegetarian diet. And now there is a globalization and so-called development as such, and that kind of trend has resulted in a low fiber diet and calorie rich diet. So that dietary habits are changing, and because of that the incidence is increasing in Eastern countries. This is a very interesting issue, but anyway, the one of the factor, and the factors are risk factors which are considered as the rising rates are attributed to changing lifestyles such as eating calorie rich low fiber diet, excessive use of red meat and processed food, and physical inactivity. By region, in the northeast, the incidence is quite high compared to south regions of India, and by age as such, from Indian statistics, the adults increase, the rate has increased by around 30%, and it's higher in men than women. As far as the causative factors are concerned, one of the major studies done throughout the world, like a global study, where more than 1 million patients, adults were screened and investigation for and followed for 26 years. Quite a huge study. The reference is here, association of dietary inflammatory potential with the colorectal cancer risk as such, that article. It has given a very extensive study, and by that the conclusion is pro-inflammatory diets which have red processed and organ meat have really been the cause for the this rectal cancer, and risk is higher in overweight and obese men, and in lean women. This is a very sort of the statistical observation. The incidence of rectal cancer is more in obese men, whereas lean women. And reasons, of course, there is no definite reason. Risk also has increased in men and women who do not drink alcohol. This also is alcohol may not be having some direct relationship with this. This is what the conclusion of the study which is presented over there. That pro-inflammatory food, which is classified as pro-inflammatory food, are red meat and processed meats and cured meats, refined grains including white bread, white rice, pasta and breakfast cereals, snack foods including chips, cookies, crackers and pastries, sodas and other sweetened drinks, fried foods. These are classified as pro-inflammatory food, and they are now proved to be being one of the causative factors for the cancer as a whole, rectal cancer specifically. A meta-analysis of 22 studies throughout the globe, again another of the study, which also has suggested the dietary fiber intake could be having a protective factor against rectal cancer with clinically relevant reduction in rectal cancer risk. Again, one more study. Now, these kinds of the studies are being presented, and in that study, alcohol and tobacco are associated with the high risk as such. One more of the observation which is done is the post cholecystectomy. After the cholecystectomy, the incidence of rectal cancer is increasing. The cause may be two reasons: because of the improper bile flow after cholecystectomy, the colonic bacterial colony has changes, and this increases to carcinogenic bile acids and byproducts, which gives again the chances of increased rectal cancer following cholecystectomy. The types of the carcinomas are in the colon. The 98% of them are the adenocarcinoma, whereas the rectal cancers mainly are the squamous cell carcinoma. Now there could be the carcinoids, lymphomas, and sarcomas. Squamous cell carcinomas, they develop in the transition area of the rectum and the anal verge. That's the most common site where it starts with, or it could be at the anal area also, either below that anal area. That anal carcinoma is something different. Rectal carcinomas, majority of them are either the adenocarcinoma or the squamous cell carcinoma. Approximately 10% of the adenomas will develop into adenocarcinomas in due course of time. That's initially they are benign and they become malignant later on. As far as the pathology is concerned, the theories, there are certain theories. One of the theories, patients who have a coli polyposis, adenomatous polyposis, or either they may have the real visible polyposis or the gene which is responsible for that could be present in the pathway. It could be resulting in the carcinoma. So that's one of the theories which are mentioned, like adenoma developing into a carcinoma in the rectum, as well as this is common for colon also. Or hereditary non-polyposis colorectal cancer is another issue. Ulcerative colitis resulting in the dysplasia is another of the causes. These factors are common for both the colonic cancer as well as the rectal cancer. And they are mainly of three categories based upon the gross shape which is seen in under the microscope, or the what we see gross as a tubular or tubulovillous or villous adenoma. This classification is based upon what you see as a cellular structure under microscope. Now, as far as the clinical symptoms are concerned, the colonic cancer, rectal cancer, the most common symptom is a bleeding per rectum. In 60% of the patients, it presents with the bleeding per rectum. The characteristic presence of the bleeding per rectum would be the blood would be fresh color or a frank blood, unlike that of the colonic cancer, where the blood tends to be darker or anchovy sauce colored or this brownish color. Here the color tends to be bright red, and usually rectal carcinoma, the bleeding would precede this defecation. Before the defecation, the patient would have a bleeding, and after the defecation, the patient may still have some sort of oozing from the area. That's the typical presentation. And the other common clinical symptoms are change in the bowel habits, like about in 43%, and usually often in the form of diarrhea. And it may be that trend of the diarrhea may even relate to the type of the food you consume. There could be a feeling of incomplete evacuation. That's another of the issue. In older textbooks, that feeling of incomplete evacuation is presented as the major clinical symptoms, but now statistically it's observed like that kind of a symptom is not necessary. That would be seen only when the size of the mass is quite huge, and that produces a pressure effect upon the rectum. But in the early stages, if you have to have an early diagnosis, you need not wait up to that kind of a symptom or tenesmus or trismus. That's where the patient would have a feeling of incomplete evacuation, suggests of a huge size and this delayed clinical symptom. Occult bleeding occasionally may occur, though it's a frank blood in majority of the cases. It could be occult blood rarely in patients of rectal carcinoma also. Majority of the patient it would be frank blood. Abdominal pain also may be presented as a colicky pain and with bloating. Some of the patients may have a pain in the back also due to compression of the nerve trunks. Many times the clinical symptoms may mimic that of some sacral nerve compression, which may lead to a error in the diagnosis. Urinary symptoms also may occur if it invades the bladder or the prostate. Vague symptoms like malaise, a feverish feeling or pelvic pain, which also can occur involvement of the nerve trunk due to acid. Or there could be acute emergencies like peritonitis or perforation or jaundice due to liver metastasis also could be the presentation as such. The most important part of the examination in case of rectal pathology would be digital rectal examination. Digital rectal examination is quite vital, and with the digital rectal examination, most of the rectal cancers can be diagnosed, whereas colonic cancer cannot be diagnosed with the rectal examination. And the rectal examination should may suggest about the presence of either ulceration, which can be felt, or there could be pararectal lymph nodes which are palpated, or there could be sphincters or prostate or vagina. These may be adhere to the rectal structure, or sphincter function could be affected. There could be either a increased tone or reduced tone of the sphincters as such. So rectal examination, it has to be careful. Fingers should be sensitive, and that can make the diagnosis of rectal carcinoma in a good number of patients. Though the sensitivity of rectal examination is considered to be lower. A rigid proctoscopy, which we do regularly, also can help in the examination of the condition. As per the data, the global data presented from major sources of examination, the digital rectal examination in primary care, that's in general where the persons are moderately trained, the doctors, the physicians are moderately trained, can have a error, and the sensitivity is considered to be 0.762, that's around 76%, or specificity is around 91%. So even in untrained hands, the sensitivity is moderately high, but there is always a possible risk as such. Predictive value, that's early diagnosis, and absence of that could be, tumors could be, again by digital examination it could be comparatively lower for the prediction of the possible tumor, but the negativity, if you a thorough digital examination done, you can definitely assess them. The presentations on this rigid proctoscopy, they can be visualized with the proctoscope as either the masses, either sessile masses, or there could be ulcerated lesions with the necrosis, or widespread, wide-based masses could be seen. So either sessile pedunculated, where there could be a narrow pedicle-like connection with the area and the mass could be felt. A polyp, a benign polyp would be having a smooth shape, and which may be converted into a wider based polyp or ulcerative tumors. These are the common findings which are seen. The presentations again could be of different types. Either the lesions could be as a depressed one, they are classified as a depressed type, or laterally spreading type, or protruded type, where you may see the projection over ulcerative type. Among the patients whom we see, in majority of the patients, it's the ulcerative type which you see in our area. Among the patients whom we have seen with the rectal cancer, majority of them are ulcerated area, and ulcerated lesions are not so easily felt by the digital examination. Digital examination may fail if your fingers are not sensitive in ulcerative lesion, whereas proctoscopy, anoscopy, that rigid proctoscopy can give you that idea. As well as the staging of the tumor is concerned, the staging is done based upon the depth of the lesion. A lesion which is limited to the mucosal membrane is T1, and if it is submucous layer, T2, submucous layer and then muscularis layer also is involved, T3A, and then depending upon the extension like 1.5 millimeters beyond the muscular area is T3B, and so on up to T3D, where it goes up to around 15 millimeters. And T4A is which has crossed the reach to the serosal layer, and a tumor which has gone beyond the serous layer involved the adjacent organ like prostate or bladder or the uterus, then it becomes a T4B. That's exactly how it is classified as such. The same issue. And similarly, the nodal metastasis, regional lymph nodes which cannot access this NX, or then N1 is metastasis 1 to 3 regional lymph nodes, N2 is metastasis in 4 or more regional lymph nodes, which can be done by the investigational process. The staging which I have suggested earlier, the same also could be made that T1, T3 stages also can be considered or presented as a stage 1, stage 2, stage 3 as such. The stage 0 is where there is no visible or palpable mass. Stage 1 is there is a tumor confined to the bowel wall alone. Stage 2 is a tumor replaces a muscularis propria but does not extend beyond the intersphincteric plane. Stage 3 is when the tumor invades the intersphincteric plane and lies within the 1 millimeter of levator muscle. Till these 3 stages, the patient would not have tenacious muscle. That feeling of incomplete evacuation would not be presented till the stage 3. When it reaches stage 4, where the tumor invades the external anal sphincter, and then the patient would have the tenesmus or the incomplete evacuation, and that's the importance of the clinical symptoms to be studied. Now, the penetration or extension of the lesion can be better measured with the MRI scan, where the tumor penetrating into the surrounding tissues, involvement of the adjacent tissues, that can be easily measured with the MRI scan, and MRI scan is necessary. As far as the treatment is concerned, the early stages cancer, the present trend of surgical treatment is a transanal excision through the anus. With the fiber endoscopes, the surgery is done, the tumor is removed locally. Whereas endoscopic microsurgery is a local excision that uses special operating proctoscope, which has become now popular, and a safe surgery. The complications are lesser and the recovery period is quite high. Earlier, in the previous trend was to have a complete anal resection and having a colostomy, but these days that colostomy is suggested as the last resort only when there is no other option. Rather, colostomy is postponed. Rather, the trend is to depend upon chemotherapy and radiation. In those who have a involvement of the visceral layer or the serosal layer, a low anterior resection and anastomosis, colonal anastomosis also may be suggested as the treatment. As far as the prognosis is concerned, as per the data again, the 5-year relative survival period of rectal cancer is based on SEER data staging as such, and the staging, if it is a localized early stage, then the survival period of 5 years is achieved in 90.9%. If it has reached the regional lymph nodes, then it is 72.8, distant lymph nodes the 15.1, and where the exact trend is not known is 60.5%, and in all 40.5%, in all the stages it's around 65. This is about the data presented over, and this data is based upon the current trends of chemotherapy and radiation. So the present trend is to go for chemotherapy and adjuvant chemotherapy as such. That's about the rectal cancer. The next part is about the anal cancer. Important from our clinical point of view, because majority of the patients whom we see are of that category, where the patient will have anal complaint, like presenting with either symptoms which resemble that of hemorrhoids or fissures or so on, and a possible error in the diagnosis could be quite high, and hence it has to be carefully assessed. The anal cancer is usually refers to anal squamous cell carcinoma. Earlier, if you see the older text, there are many classifications like keratinizing, non-keratinizing, or basal cell carcinoma, etc. But now WHO classification, in the recent classification modifications of the recent classification, these all previous terms are removed, and it's only the squamous cell carcinoma which is maintained as such. And the most important fact about the squamous cell carcinoma is its relationship with the human papillomavirus study. The human papillomavirus infection, particularly the stereotypes of 16 and 18 in the human papillomavirus involving this area, are they would be present or is quite related to the anal carcinoma as well as vaginal carcinoma. Of course, in India, the majority of the HPV virus patients, involving patients, they develop the involvement of the uterus or vagina. The female genital organs are more frequently involved, whereas in the cold Western countries, it's also related to the anal carcinoma in a higher number. And this kind of difference is attributed to the serotypes of the virus. The serotypes of 16 and 18 type of the virus is considered to be more responsive for the anal involvement than the genital. Now, this is another bit advanced virology issue which may not be used in the regular clinical pattern. And the studies of this HPV virus is done throughout, and now these days HPV virus vaccine is considered in the National Health Program in India also, based upon the study elsewhere. Now in India we do not have a data like how far it has reduced the incidence, but based upon the study in a Danish study, it's found that the HPV vaccine given before the age of 17 years has substantially reduced the risk of anal high-grade squamous intraepithelial lesion and compared to the general population. Now this is from the Western study. In India now, these days, the HPV virus vaccination has become a routine thing, and it has to be done at an early stage by the age of 17 years or below that. Now the whole process of the virus developing into a cancer is a slow process, and the clinical examination, now even if you take a biopsy histopathology examination, the histopathology may not show the changes in early stages. It takes a long time. So this is true for both the cervix cancer as well as the anal cancer. The picture which I have presented is from the cervical cancer. The similar issue would be also in the anal cancer, that the normal tissue gradually results in mild dysplasia, and then gradually it results in moderate dysplasia, and carcinoma, invasive carcinoma, it occurs at a later stage. On an average, these changes take around 5 to 6 years changes to occur, or at times up to 15 years. So when you do the smear study, now this in the pap smear study in vagina, the cervix area, whereas in the anal issue also, when you do the microscopic study, these would show the dysplasia of different degrees. Now these dysplasias were earlier named with the different names like Bowen disease or high grade or low grade epithelial lesions, etc. But now the nomenclature has been like, without going into that confusions, the nomenclature is mentioned as a carcinoma in situ 1, 2, 3 and so on. CIN is a carcinoma in situ. That's how the nomenclature is done now. Earlier the nomenclature was where either Bowen disease or high grade or low grade squamous epithelium, squamous intraepithelial lesion, that's LSIL or HSIL. But microscopic study of the smears in the anal, it's a biopsy as such, can give you an idea of this, and early stage changes may be identified as dysplasia. Later only it becomes carcinoma or invasive carcinoma. The progression of a low grade invasion, that's initial stages, would be has been shown to occur in 10 to 11% of the cases with the HIV positive individuals, and high risk of conversion in even if their HIV disease is under control. So the relationship between the HIV also is now known, and even if the HIV is controlled with the antiviral treatment, the incidence would be quite high, like abnormal anal cytology in HIV negative and HIV positive, where the CD4 count is lesser, the incidence will be more. So majority of the patients who have these dysplasias, they may also have HIV positive. So a investigation or test for the HIV is also important. The comparative incidence of cervical and anal cancer. Now, in HIV and HPV, both these investigation conditions, HIV negative patients having cervical cancer compared to the HIV positive, the number would be many. Now, this picture would be, is just suggestive of the HIV positive are patients either HIV negative or HIV positive patients. Cervical cancer incidence is also higher. Anal cancer in women and men, and of course in the persons who have the sex of same sex, sodomy, men with the sex, men sex with the men, MSM is men sex with men, the incidence is much higher as such. So as well as the data, Indian data, now this is about the data from the India, projected incidence of HB virus related cancer incidence in 2025. Now this data is quite important because the HPV vaccine now has become or has been accepted as a national health issue, and it has become now mandatory. And from the clinical point of view, practice point of view, advice to the patients to have these vaccines has become now almost a regular issue. And there are certain legal and ethical issues too, and from that point of view this data is important. The possibility of development of these cancer, different types of the cancers related to the HB vaccine or HB, total HB related cancers, the projected would be around females 96,000 and males around 24,000 in 2025. Anal cancer compared to the vaginal, this vulva or vagina, total cervix cancers, they are comparatively lesser in India. Now this data is about specific in India. Cervical cancer risk prediction is in 85,000, whereas anal cancer would be around 3,002. Oropharynx cancer in men is more. So that's about the issue. Anyway, in total, in all sides put all together, the possibility of development of the cancer in related to the HPV incidence is quite high, and that's why vaccination with the HPV vaccine now has become a national program as such. The SEER data, this is from the Western countries, throughout the maybe a global data. Annual incidence rate of new anal cancer did not change significantly over 2012 to 2020. This is from the over the world global data, averaging 1.9 cases per 1 lakh person per year, while age-adjusted death rates rose. The death rates have increased by 5.1 per each year by 2013 to 2020. So the whole issue is the prognosis. There is a significant delay in the diagnosis, and hence the prognosis is becoming poor. Clinical symptoms are the mainly the anal pain or pelvic pain could be the initial most clinical symptom. Patient may have some abnormal sensation in the rectal area, local wetness or irritation. There could be a prolapse of the tissue from the area which may be misdiagnosed as either anal prolapse or maybe hemorrhoid or such, or there could be even any other possibility like diagnosis like a fistula or maybe a fissure also. That could be the possible diagnosis because of the symptoms which are presented. Incontinence of platters or liquid, when the patient has a liquid stool, there could be incontinence, which also could be a presentation of the anal cancer. Obstipation is a rare phenomenon. Approximately 90% of the patients wait for 6 months or more to seek medical care. That's the usual thing, because the patients would not come to the examination initially, and in all such patients digital rectal examination and inguinal lymph nodes are absolutely essential. So it's not enough if you palpate only the rectal area. Digital examination, the examination of suspected anal cancer should involve these inguinal lymph nodes too. As per the data suggested now, throughout again this is global data, the diagnosis of anal cancer is quite delayed, and it's considered to be 7.4 months and 3.2 months after the first visit to the physician. See, this data from the Western countries where the people are rather, they come to the physician early, and in India the situation could be still more. We do not have a corresponding Indian data. The average time taken for the patient to visit the physician for the first time would be 7.4 months, and the physician may fail to make the diagnosis in the initial examination. When the patient is following up the physician for 3.2 months, the diagnosis of anal cancer is possible. Now this suggests about the complexity of the issue and the errors which can occur. The presentation now quite important. I have collected a few of those model pictures which can produce the confusion. The anal cancers can be presented like, which may mimic that of a fissure, but this fissure like wound would be quite wider, and usually the conventional fissures would be presented either in the anterior or posterior midline, whereas the anal cancer which mimics like a fissure could be anywhere. It could be in the midline or the other way. The most important part is when you palpate the anal area, before you put the finger in, if you palpate the surrounding area throughout, if there is some variation in the consistency, some sort of induration, hardness felt, then there is some lesion which is not fissure or piles. Either it could be a cancer or it could be a abscess developing. In abscess developing, there would be tenderness, whereas in cancer tenderness is not essential. So that's the important issue. Or it also may present as some skin lesions, thickened lesions, or the patient may have itching pruritus, or it may even present with a mass which is protruding, a small mass which is protruding. In these conditions, the sphincter involvement can be seen from the exterior, like a asymmetry in the anal opening. When the anal opening has a visible asymmetry, that's again an issue of concern where this sensitivity should become more alert. Your examination should be more careful. Or even it could be like atony of the sphincter. The sphincter becomes lax, and hence the opening may remain patent or set with maybe surface lesions, which also could be the sign. There could be some confusion with the anal cancer and Paget's disease. Paget's disease is a chronic inflammatory pathology. Ideally, when you read about Paget's disease, is about the mammary involvement, the breast Paget's disease. But extra mammary involvement of the Paget's disease also are known, where the patient may have anal margin having that roughness, which often producing confusing with the cancer. But this again needs a histopathological study, and only with the histopathological study you can make out that. Patients having condylomas, that could also be a presentation of the anal cancer, where there could be multiple polyp-like appearances, which again need a proper histopathological study as such. Only with the histopathological study can confirm, and every condyloma is considered to be a precancerous, so you have to have a risk as such. Conditions are like fistula, when the patient may have a fistula opening with some areas of induration around, and fistula with the multiple openings, they have to be always seen with the cause of a caution as such, with a significant caution, and they need that thorough investigations, even maybe MRI scan, to confirm that there is a involvement of the tissue. In a MRI scan, which otherwise clinically may be diagnosed as a fistula, it can show that invasion of the tissue and that would be necessary to make the diagnosis. A cancer which also may be misdiagnosed as hemorrhoid. Now this is from one of the reports where the cancer was diagnosed as hemorrhoid in the beginning, and later it was found to be a hemorrhoidal mass which has some irregular surface, and maybe the consistency is harder. That has to be carefully seen. And as per the global data, again a large number of studies, patients' data seen from Western countries, again over half of the anal cancer patients were initially misdiagnosed, and 25% were symptomatic for more than 6 months prior to the diagnosis. So that shows the possible errors which can occur in making the diagnosis of anal cancer, and that's why whenever you do the digital examination, when a patient comes with the complaints in the anal area, which often we see in large numbers in our setup, we have to be careful and the diagnosis has to be made. The imaging studies for the anal cancer could be either CT or scan of the chest, abdomen or pelvis to evaluate the enlarged lymph nodes or metastatic spread. The current trend is transrectal ultrasonography. Transrectal ultrasonography has a very high sensitivity, where with the transrectal ultrasonography, the lesions can be made out, the extent of the lesion, involvement of the lesion, penetration into the other tissues also can be made out accurately. Grading of the tumor would be TS is a high grade squamous intraepithelial lesion, which was previously considered as carcinoma or in situ or bovine disease. That's a T in situ, tumor in situ. T1 is when the size is more than 2 cm, and T3 is when the size is more than 5 cm. T4 is any size which invades the adjacent organs. Similarly, nodes N0, no regional lymph nodes involved, whereas N1C is metastatic in external iliac with the multiple nodes. As far as the treatment is concerned, surgery has a limited role. Earlier, surgery was considered to be the first choice of the treatment, but the current guidelines say the other way. The surgery has a limited role in the treatment of cancer, and the current guidelines consider local excision appropriate only for selected patients with the superficially invasive squamous cell carcinoma or abdominal margin, and radical surgery is indicated only for recurrent cancer of the anal canal after non-operative therapy, and the non-operative chemotherapy and radiation would be considered the standard treatment would be as such. Then vaccination against HPV should be considered as a preventive measure. With this, we conclude the anal cancer also, and with this we conclude the gastrointestinal tract tumors in brief. So, though we have limited only a few conditions, I think we have covered the major issue. So from the next session onwards, we will start with the leukemia. Then whether prostate cancer can easily spread. See, in general, there was a question like prostate cancer. Prostate cancer usually spreads slowly. Of course, it can involve the rectum even, that's true, but compared to the rectal cancer, the prostate cancer spreads slowly. The possibility of a rectal cancer spreading into the prostatic tissue, involving the prostatic tissue, is more than the other way. That's the real fact as such. And about the prostatic cancer, we will discuss later when we discuss about the urogenital tumors. So in the next we discuss about the leukemias based upon the incident, right? Okay, then we will conclude today.